Good morning. Do we have Professor Helen Herrman here? Oh, hi.
We do. Hello.
Hi. Very,
Good morning to you.
very good morning. And I understand it's good afternoon there. It should be about 1:30. Yeah.
It is
So,
already, yes.
yes. Right. And we also have a number of our students who have already joined, and many more should be there. So we have the whole department, and some of their Helen just to introduce you to some of our very respected senior alumni of the institute. You know Professor Dr. Colonel Rajinder Singh, who can be seen on the screen, and
How do you
also
do? Yes.
yeah, and also I can see the name of Professor Srinivasa Murthy.
Yes.
Yeah, you would have. Yeah, that's right. Yeah. Hello, sir.
Yes, we've greeted. I'm very honoured to see these senior colleagues as
Oh
well as
yes, oh yes. As well
delighted to
as
see
my
everybody.
all our faculty colleagues and other people, and all our students, both the trainees as well as senior residents. So it's an absolute pleasure, ladies and gentlemen and friends, to have with us today virtually. But then now virtual is more real than ever. Professor Helen Herrman, the immediate past president of the World Psychiatric Association, but much more than that, really. So before we come to that, with your kind permission, Helen, just allow me a 1 minute to introduce this thing called the Distinguished Speaker Series, in which we have had people like Professor Norman Sartorius, who kickstarted the series really, and then Professor Afzal Javed, the current president WPA, and Professor Sir Robin Murray from the King's College London, UK, and you are the fourth one here. So this is something which we create for the department, and later through YouTube for the world, where we have eminent people who in the area of psychiatry and associated mental health, to talk on various aspects which are of their choice, but which are essentially of a motivational, inspirational nature, so our students can get a glimpse of the world's best. That's the basic idea, just to motivate them, to inspire them. And this had started during the pandemic times, and we have been able to, this is an occasional series, so we have been able to continue that, and you are our latest guest in this in this distinguished speaker series. As can we show it on the slideshow, Swapnajit? Yeah. So just a very meanwhile, for the group who do not know Professor Helen Herrman, a super brief introduction, because otherwise the introduction will take all the time and we won't have any time left for the actual talk. So Professor Helen Herrman is AO, and this is one of the highest orders. She's an officer of the Order of Australia. She's a psychiatrist and a public health physician who has worked across these disciplines in varied ways over time. And she's now a Professor Emeritus of Psychiatry at an institute called Orygen. Now that was interesting. So I did a little bit of study to find out what is Orygen, and I realized that this, I think we'll hear it from her probably. So I'll leave it at that. Director of Orygen and director of the WHO Collaborating Center based in Melbourne, Australia. And she's, as I said, she's appointed as an officer of the Order of Australia. And she's a former president of WPA, as I said, the immediate past president, and of the International Association of Women's Mental Health. She has been earlier in Vincent Mental Health, Melbourne, and etc. There's a long list of her what do you call that? The H index, according to Google Scholar, reads as 65, and there are some 50,000 citations, and the latest, but more than that, I think she has devoted her entire career and life for various kind of public mental health related activities of various nature. Again, I won't go to the details of that, but the latest one was a Lancet series commission, which she's going to talk about, I'm sure, and that was about depression, and that was about whole aspects of depression, a wonderful, extremely complex and comprehensive series on Lancet-WPA Commission, Time for United Action for Depression. And hence, Helen is going to talk about today, my dear friends, on one of the best topics that one can think of, the best ways to prevent depression. I think without any further ado, I will simply hand over stage to you, Professor Herrman. And again, it's our honor to have you with us. Yours, please.
Thank you so much, Professor Debasish Basu. It's wonderful to, I feel very honored, as mentioned, to be invited to contribute to this series and to have your friendship and this possibility to meet you and other colleagues, some that I've known and worked with over the years, and new friends and colleagues as well. So I'll just share my screen, and thank you for introducing both me and the topic. As you say, this is a provocative title. It's one that, and I know that you, Debasish, you share the public mental health perspective with your distinguished editorial work as well as your other work in various other ways. So this seemed an appropriate title, but I hope by the end of this topic that by the time those people who do find this provocative might think that it's not quite so provocative and embrace it as well. As you mentioned too, I'm speaking to you from Australia, or half a world away, and we're only 5.5 hours ahead though, so we're not that far away around the middle of the globe. And Orygen is the National Centre for Excellence in Youth Mental Health. So I speak from Orygen as well as from the University of Melbourne, the Centre for Youth Mental Health in that university. So I thought, although we're half a world away, as mentioned, we have several topics that bind Australia and India with our growing relationships, but one that's been there ever since I first had the wonderful opportunity to come to India 20 years ago or more. The topic of cricket has always come up, and this time, as I was saying to our host, that I didn't know whether to mention the women or the men, but I thought give the women a turn. We've just had the finals of the women's cricket T20 series, and here's a great photograph, I think, of the women of our two countries interacting. Probably the less said, the better about the men's test series. We'll come to that. So today I thought, in talking about the best ways to prevent depression, that I'd begin with a few remarks on global mental health and see where that leads us in terms of thinking about prevention, and then come to the Lancet Commission that you referred to and its recommendations that span quite a few areas of treatment, prevention, research, community action to promote public understanding and prevention and care globally, to consider particularly the preventive aspects of that. And the consideration that prevention is critical to reducing the burden of depression, just as it is with any other health condition, such as heart disease or cancer. And what are the roles of health practitioners, we as psychiatrists, nurses, social workers, psychologists, and other professionals in this area, and whom do we partner? So thinking about global mental health and prevention, there was another Lancet Commission in 2018 on global mental health and sustainable development, led by Vikram Patel and colleagues. And this expanded the agenda from reducing the treatment gap, which had been an important focus, a critical one, but it was only part of the story. And as we'll come to with depression more specifically, and as throughout health, treatment can never close the or reduce the burden of depression sufficiently. It always needs complementary preventive and other actions. Also, the focus was on intervening in childhood and youth, and as we know, mental health differs from other health conditions in that the main conditions that trouble people throughout life arise earlier in life than other health conditions. And there can be interventions early in life that are fundamental to reducing the burden and addressing trauma and associated mental health problems. We go back to some of us with longer careers and memories will be well aware of the work of Professor Leon Eisenberg and Arthur Kleinman in Harvard Medical School 20 years ago with colleagues. They produced this book, World Mental Health, Problems and Priorities in Low-Income Countries. And the foundational idea of cycles of social disadvantage, in a sense, has been reinvented as syndemics in the current way of thinking. But the idea that there are chaotic neighbourhoods or areas, whether they be slums or refugee camps, where poverty, violence, gender discrimination, other forms of discrimination increase the risks for mental ill health. And they, in turn, when people become ill, they have additional barriers to health and livelihood. And on the left-hand corner of that of this picture, I've listed the determinants of mental ill health. That's the more modern parlance, introduced for health in general 15 years ago, and now increasingly embracing mental health. And mental health is seen as the foundation for health and certainly an integral part of health. But the determinants, as with other forms of health, are poverty, gender discrimination, violence, including violence in the home and violence in the streets, as well as wider spread war and conflict, and social exclusion that often stems from the ill health as well, but can precede or follow it. And the other major determinant of mental ill health, as the clinicians in our group will know, is major physical illness. When people become ill for the first time in middle age, it becomes a much more close search for a physical comorbidity. So this commission in 2018 really underlined the idea that mental health can be improved through interventions beyond the health sector. It also, of course, emphasised that there are cost-effective solutions to mental health care, but without these combined actions on mental health globally, it will be impossible to meet the Sustainable Development Goals. These are the goals established a decade ago by the United Nations, and I'll come to talk a little more about them in a moment. So here are a number of these Sustainable Development Goals. I think there are 17 overall. And this was an initiative led by Professor Crick Lund from South Africa, associated with that Lancet Commission. In fact, the citation is there. And showing how much mental health is intertwined with our societal, community and family and individual lives. So the gender equality, economic factors such as poverty, inequalities, employment and unemployment, the neighbourhood, it's the availability of sanitation, energy, and cities and communities that work for people. Then environmentally, climate action, peace and justice and strong institutions. One of the most important, the social and cultural factors include quality education. And each of these has impacts at each of these so-called ecological levels, which I won't go into detail about now, but we can discuss later as well. So the final word on this commission, it reframed mental health on a number of parameters, particularly the intertwining of nature and nurture, so that the social and biological determinants of mental health and mental health problems interact across the life course, right from gestation through adolescence, middle and later age, and then seeing mental health as a fundamental human right for all people, particularly for people whose mental health is at risk because of some of these vulnerability factors I've mentioned. And it also mentions the importance of working with people with lived experience of mental ill health and their families, as well as other community partners. Now here's a slightly complicated diagram, but one that you can find in that commission online. And it looks at protective and risk factors in the early life course. So I'm not showing you this so that you study all of these right now, but just to get some sense of the range of factors that impinge for better and worse on the status of mental health and the risk of mental ill health and the actuality of mental ill health for people before and after birth and intergenerationally, so that poor mental health can be begin right with an unwanted pregnancy, a child born very quickly after another, to perhaps a young mother, a child mother, inadequate care before birth, and a high-risk pregnancy, a mother who doesn't know or have the possibility to nurture and stimulate a child, and the development of or developmental problems for which there is little support, problems in family, in school, and risk-taking behaviours in adolescence and youth, and going on to poor engagement in school or work, for example, and the converse being shown at the top, including secure caregivers and positive parenting and so forth. And these messages are broadly underpinned in the 20-year anniversary of a report that certainly Dr. Murty is well aware of, and most of us are, of the World Health Report on mental health, released last year and called Transforming Mental Health for All. It iterates these messages and reinforces them and develops them on health promotion, prevention, treatment for all, community access, and the power of people with lived experience and their families, and the importance of strengthening communities. So turning now to the Lancet-WPA Commission on Depression, Time for United Action on Depression. This is a group of 24 people from a range of disciplines, including psychiatry, psychology, nursing, epidemiology, primary care, public health, and so forth. It was a wonderful collegial group. We were supported closely by the editors of the Lancet, including Dr. Richard Horton, who encouraged us to change the world. And we've done our best to recommend that. And I'd like to acknowledge the funders, the University of Melbourne, the American Foundation for Suicide Prevention, the Wellcome Trust, and the support from Harvard Medical School and the Wellcome Trust, and the support from a range of groups for consultation with people with lived experience of depression, including young people, on the proposed recommendations. And United for Mental Health, the Global Mental Health Peer Network, and the WPA groups were instrumental in that work. So this we set out now about 5-6 years ago, full of enthusiasm, to address a neglected global crisis, as the Lancet put it to us, to advance understanding of the nature and causes of depression, to synthesize evidence on prevention and care and identify knowledge gaps, and recommend actions to promote public understanding, prevention and care globally. So you can see that prevention is there, it's part of the work, and became increasingly important in our thinking as we went on. In thinking about public health and depression, we put together this with Christian Keeling, one of the senior editors, with myself and Vikram Patel, put forward this graph on the global burden of ischemic heart disease and depressive disorders over time between 1990 and 2019. You can see that the top line, the red line, the global burden has decreased over time, whereas that for depression, which is at a different level, but nonetheless it's remained constant over time. And we can say that the difference is likely to be that there's been a major change of thinking about heart disease since the 1950s, certainly. When we move into the 1970s, people in various parts of the world, including in Northern Europe, North America and elsewhere, really worked closely on the idea that changing populations' experience of diet, their opportunities for exercise, and reducing the smoking of tobacco, these were all factors that have been shown over time to have reduced rates of heart disease in populations that have introduced these. Conversely, populations where smoking has continued to rise, for example, this decline in the incidence of heart disease has not been as marked. So this is a lesson for us in mental health, an example of how public health has been less influential in mental health until more recent times, apart from important exceptions to that rule. This is the burden of disability rate related to depression across the life course in high, middle and low income countries. So the high income countries are the green, little green parts of the columns at the top, and the other parts of the columns relate to low and lower middle and high middle income countries. So you can see that the bulk of the burden of depression is borne by young people in low and middle income countries. Hence, it's particularly important in global mental health and potentially in a country like India. And I might add too that there was an interesting paper to which people have drawn attention, published in the Lancet in November 2021 by the Global Burden of Disease Group, which showed that an estimate of an increase in burden of disease related to depression during the first year of the pandemic, a considerable increase, about 25%. So depression and psychosocial disabilities go hand in hand, that living in a refugee camp or a slum or experiencing disasters or child can precede or follow depression. And so child maltreatment is another important antecedent for many health conditions, including depression. Depression kills. The causes of premature mortality that John Steinbeck refers to here poignantly are not only suicide, but also premature mortality from cancer, heart disease, diabetes, and other physical comorbidities, as well as the substance abuse and other mental health comorbidities. But despite its prevalence, depression is poorly, or people receive relatively little access to care. That in high-income countries, it's said that about half the people with depression have contact with services, although only a fraction of those, showing there as 12% in the second blue column, receive adequate combination therapy. And the proportions in low and middle income countries are much lower. But having said that, there have been studies that show that indicate that even were all depression to be adequately treated, that could only account for about a third of the burden of depression. Even were we to detect, recognize, and communicate adequately with all the people living with treatable depression, we should still not be able to pull it down from about twice the level of disease burden reduction that we have now. So what curtails us as much as anything are the myths about depression and the stigma related to that as well. So myths such as it's a personal failing, or it's a biomedical invention, or it's a culturally bound condition, prevent people from overcoming the stigma and seeking help. And the former Prime Minister of Norway has given his time and efforts strongly to supporting the idea that he wants to combat stigma by telling his own story. He says this is a common problem in all countries. So finally, the Commission is overall wanting to recommend interventions at multiple levels to reduce the burden of depression, to address public understanding and political will, and to drive prevention at societal and individual levels, along with access to effective care. And it has several key messages, but I want to look particularly at the message related to prevention. I'll come back to some of the details about this later, but prevention is essential to reducing the burden of depression and also achievable. And we can look at complementary approaches at different ecological levels, the whole of society level at the top, various settings at the middle, and individual and family interventions across the life course as well. Before I do that, I wanted to spend a few moments thinking about what we know about depression and mental ill health. There was a famous publication in 1994 from the United States, the National Academies of Medicine, led by Professors Mrazek and Haggerty. And they introduced this half wagon wheel that people refer to very frequently, have referred to since then. And at that point, 20 years ago, they were, 30 years ago, isn't it? They were looking at prevention, treatment, and maintenance. and prevention in terms of universal, selective, and indicated. And that remains, that way of thinking about prevention remains an important one. Universal interventions that influence everybody in a population, whether or not they have a particular risk for depression. Selective interventions are those that that aim to support people with an increased risk of depression, whether that's because of the setting they live in or whether that's because of their circumstances, such as bereavement, where there might be groups of bereaved people in a primary care clinic. Or indicated are those people who are already experiencing some symptoms of depression but don't have a diagnosable disorder. There have been two further editions of this, this publication, and it's changed somewhat in a number of ways. And in 2019, right before the pandemic, this publication that was brought to the attention of our commission, in fact, by Dr. Myrna Weisman, another member of the commission, on fostering healthy mental, emotional, and behavioural development in children and youth. This was a national agenda for the United States. And here they reinforced the role of mental health prevention, of promotion, which is the idea that well-being can be promoted as well as reduction of risk for mental ill health. So promoting health as well as prevention, the actions often overlap, but the concepts are somewhat different. But promoting mental health in the best ways possible is seen as important to the success of prevention, treatment, and maintenance of good mental health. And you'll see there in the middle that universal, selective, and indicated are still there. And they describe rather nicely, I think, that the influences on mental, emotional, and behavioural health come from the intertwining of complex neurobiological processes with physical and social and environment from before conception through adolescence and across generations. And here is another diagram that shows, you can always look up through this publication, but just to show while there's intense work on the nervous system and the endocrine system and other biological parameters, this intertwining of these individual characteristics and developments with family and community characteristics and changes is the overall background to the status of a person's mental health or a community's mental health and risk for mental ill health. And to comment that the World Health Organization's Mental Health Action Plan has 4 broad objectives, and number 3 of these 4 is to implement strategies for promotion and prevention. So this has equal status with the provision of comprehensive, integrated and responsive care services and the other important points mentioned there. So coming back to the understanding of what we can do to prevent depression as a society, and here we're talking about at the top whole of society interventions to address the structural determinants of health. Now, we as health practitioners, we're not in charge of this, but we have an influence, and so our influence societally on the importance to prevention of depression as well as other forms of mental ill health in various ways is that we need to support gender equity, for instance, and decrease discrimination based on other grounds, including racial or ability grounds, and actions to support poverty alleviation. And a number of societies have started experimenting, for instance, with a universal basic income, and we as health professionals, particularly mental health professionals, can applaud those actions. Then the various settings those whole of society interventions are by nature universal interventions. They're not directed at a particular group at risk for depression. When we look at the various settings, families, schools, workplaces, neighbourhoods, and their health and social services, there are a range of interventions that could be universal. So for any school, there could be promoting the school climate and broader measures to prevent bullying, as well as there may be selective programs to support those, for instance, who may be subject to bullying. There may be selective interventions, such as families who are impoverished or have had children at risk, that they could be involved in different programs. And in the primary health care, there could be moves to detect and support people at risk for depression, for instance, elderly people who are lonely, as in neighbourhoods, social support for elderly people or for young families. And workplace interventions could be either universal or selective or indicated. Then coming to the individual and family interventions, we have a lot more evidence for these because, of course, it's more difficult to set up randomized controlled trials for the societal and setting-based interventions. But we do have evidence that it's possible to prevent to reduce the incidence of depression through cognitive behavioural therapeutic and other psychosocial interventions with people with risk factors or with subthreshold symptoms across the life course. So the overall recommendations are that researchers and research funders engage with partners, and these might be people with lived experience, they might be funding partners, governments or philanthropic partners, they might be community actors, people engaged in community development programs, to evaluate the implementation of programs designed to provide universal or selective or indicated actions to prevent depression, as well as policy changes, particularly those that might influence the financial or the discriminatory points I've mentioned, as well as educational and workplace policies, for example. And then to identify novel and underused targets for prevention. Now, they might be biological. There's a famous search for biomarkers, but they could also be social targets. And I think it's important to emphasize here that prevention, wherever it's used, whether it's prevention of heart disease or prevention of depression, we don't always need to understand the mechanisms. I think the trials to reduce the impact of smoking on cancer and heart disease that were conducted by Sir Richard Dole and colleagues in the 1950s and 60s, and that have had such profound influence ever since, these led to action on reducing smoking even before people understood what it was about smoking that caused cancer or caused heart disease. We're still working that out, but we understood the association and the causal association. Now, we have a lot of work to do in depression, but that kind of work is needed as well as the biological work. And we have a lot of work to do on precision treatment as well. That's a different topic. And then recommendations directed to the decision makers. Do we need secure investment across society to, particularly with consideration of the determinants of health across the life course, to tackle inequities, economic and social inequities in particular? So just a few words then on how we might go about some of these things. So if we think of social policies and community development in particular, and what's the role of us as health professionals in that? We know that social policies and laws, there are a number of international covenants on human rights, the rights of women and children, that most of certainly our two countries and most countries in the world have ratified. But these are not enough around the world to change attitudes and cultural practices. If we think to the extent of violence against women and children and the discriminatory practices, certainly in my country and elsewhere, the laws themselves are not enough, and the policies. So there's incomplete implementation of the laws and poor changes of attitudes. We need, in mental health, champions of the like of Greta Thunberg and Malala Yousafzai, who've been have stimulated so much interest and activity in climate action and education for girls, for example. And people like the Prime Minister of Norway have been important in that way. We also need community action, and these happen to be women in Santiago have been famous for community action. Women are always on the front line, but of course men are equally important. So if we think of community development, it's been defined as a process that the members of communities take action on things important to them, and outside expertise can be helping when asked. The most important factor in success is the empowering of community members and their capacity to strengthen communities. So this process values community wisdom, it's led by community members, and it's guided by principles of human rights and self-determination and the power of collective action. I mention all that because the importance of participation and self-confidence, particularly for younger women or for women and men of any ages, that these are important. These are also vital ingredients in good mental health, and hence we see the virtuous cycle of participation, self-confidence and good mental health that can drive a number of important actions in mental health, as well as in other topics, including reproductive rights and violence at home and in the streets and its reduction, as well as work in emergency settings and impoverished communities. This is work that's really supported by UN Women. I'll give an example of mental health in the perinatal period, that preventing depression in the perinatal period, we can think of the universal factors such as protecting women from human rights abuses like insecurity and poverty, discrimination and preventing violence at home. What can be done universally? What sort of laws, practices can be, and attitudinal changes are important there and are driven by this means, as well as in the primary health care or community settings, how to identify risk factors and poor community and poor health, and training community workers and lay people to understand depression, to understand the impact of violence and how to detect and who to refer to. And preventing depression in primary care follows those principles, but is based on participatory approaches to health, collaborating with women and their families. There's been a great deal of work particularly in childbirth and this improved safety of childbirth, I believe particularly in Nepal and India, that's drawn on training peer facilitators among women groups in rural settings. And a great deal can be done without even, benefit can be gained without any increased health spending. Whereas the drawing in community workers in primary and maternal care is also important, and the Thinking Healthy program supported by Atif Rahman and others in Pakistan is an important example. But here we have the role of health professionals, trained and supported by professionals. Well, what can health professionals do in settings like this? Well, they can only really do it together with the communities, and whether we're psychiatrists or whether we're nurses or psychologists, social workers, our curricula need to be adapted, or we can think how we can adapt curricula to do part of the training in community settings, say in schools, in places in slums or refugee camps, or in maternal and child health clinics, where the workers there need access to mental health expertise for training and support, as well as for referral when needed. And this increases the challenge of the work for professionals, takes them out of the office, as the office is important. We have a particular role with severe and enduring mental health conditions, but we also have a role to support communities in their work, in teamwork and systems thinking. For example, we can have a role in linking midwives and nurses to training and support, and that allows them to manage, to understand when there may be a problem with violence at home, for example, using digital programs or direct access. And if they have access to mental health professionals who are trained as trainers and in skills for this community-oriented practice, this would be to a great advantage. So before concluding, just to note, the culture of mental health professions is important to our work in prevention as well as in treatment and care. And if we invert the WHO pyramid of care, we have mental health professionals underpinning training and supporting leaders in primary health care. People are much more likely to listen to other leaders in primary health care, and they in turn can be trained and supported by the mental health professionals, and they in turn train and support the community workers. And as we know from this work from WHO, that community self-help is the foundation for mental health and reducing the risk and preventing depression. So to conclude, preventing depression is everyone's business across sectors at all different levels, considering the social determinants of poor mental health. It requires work across all these sectors, supported by community development and integrating with primary and general health care. And of course, is complementary and goes alongside the care for depression and other mental and physical health conditions. So thank you. I'll be pleased to engage in discussion.
Thank you. Thank you so much. Thank you so much, Professor Herrman. It has been an absolute pleasure and a very important idea to talk about and to listen to such kind of things, especially because our students, or us for that matter, many of us, we tend to generally, we are a bit, blindfolded into seeing psychiatry as a one-to-one affair. Here I am sitting in my chamber. Here's my patient walking in. I make the checklist based on DSM-5 or ICD-11 or whatever, diagnosis. I'm not belittling any of these. Of course, these are extremely important and I treat it. But you have given that wide whole world picture of the public mental health, which things we often are not aware of. So but this is not about my topics. I have Professor Srinivas Murthy, who if you recall, was actually the author and the primary lead author of the World Mental Health Report way back 2001, if I'm not mistaken,
Yes.
Dr. Murthy. So yeah, so probably we'd like to hear a short comments from Professor Murthy, as well as Dr. Colonel Rajinder Singh is also there if you'd like to. But at the same time, because for the students, I'll request the students and other people to put up short comments or questions on the chat box so we can take up some of these time permitting. So in the meanwhile, Professor Srinivas Murthy, please. Yes.
Thank you very much. Thank you, Helen, for a very comprehensive, both broad as well as specific way of looking at depression. Thank you very much. And the last sentence you made, mental health has to be a people's movement, is central to the whole thing. But I want to just touch upon why haven't we made success? Very interestingly, just this morning when I opened my computer, there was a business newsletter called Founding Fuel. The title of it was Keep to Hope, and it referred to the hopelessness experience and the new book that has come up called Learned Hopefulness, and I just was able to download it in my Kindle, where the person says the power of positivity to overcome depression. The point which I'm making is this is a topic which everyone is talking. But as Debashish pointed out, why haven't we made it a thing, a part of our work? I think mainly because we have been thinking of patient, not people. I remember about 5 years back, there was a poster put up by the Ministry of Health and Family Welfare, Government of India, where they talked about the value of meditation, yoga, and other things. And the profession went hammer and tongs to say, this is wrong, remove it. We can't talk about prevention of depression. There will be quackery and other things. Now, the other thing which I want to make a point is that whatever we do, particularly I am saying this from my last 10 years of experience of living with cancer, I realized that majority of the people with cancer who develop depression will not go to help, seek professional help. So I looked at the literature and came up with this called My Emotional Health, My Choice, where there are 10 things that are evidence-based, which you already covered it. I won't touch upon it. And more recently, with the caregivers of disabled children, we brought out a book on self-empowerment of caregivers for emotional health. I'll be happy to send the electronic version of it to anyone who writes to me. Debashish, of course, has a copy of it. I sent it there. The point which I'm making is that there is enough evidence to say that depression can be prevented, can be treated with non-pharmacological interventions. In point of fact, the most recent NICE say that exercise and other non-pharmacological things are as good as the pharmacological interventions for mild and moderate depression. Lastly, the department has been a pioneer. I'm just referring to the book by Dr. Big. He wrote, after retirement, this book called The Joy of Health, which was a series of articles which he wrote in the newspapers every week or so and brought it together. So there is a recognition. What needs to be done is three things. Firstly, we must talk about people rather than patients. Number two, we must generate local data so that we are not talking about what happened in Boston or Bristol or Brisbane, but in Bangalore or Chandigarh. The third thing is every one of our centers should become a mental health center rather than a psychiatric department. I close by saying I started my career in Vellore at Mental Health Center. As early as 1950, when they set up the psychiatry department, they called it Mental Health Center Bagayam, Vellore. And so I think this transformation is ready for takeoff. And I think you have given a very big push to it, Helen. Thank you very much. Thank you very much. And you have my email. Any one of the students who would like to get in touch with me, I'll be very happy to do that. There won't be any problem at all. Thank you very much, Debashish.
Thank you so much, sir. Helen, would you like to briefly respond? I mean, he has made the extremely important points, of course, but if you'd like to.
Yes, well, thank you very much. Professor Murthy has been my guide and friend for more than 20 years. And we first, in fact, came together, didn't we, in
yes, Manila.
WHO in Manila, in relation to that first mental health report, the World Health Report. I think you make a really important point when you say patient people not patient, or we've been dealing with patients and not people. And the caregivers are such an important group. But I like your point, your emphasis particularly on we have enough evidence, we can move, and everybody knows that war is not good for us, or living in a slum is not good for us. So but what we don't often do is measure mental health outcomes. For instance, when we work in schools or work in refugee camps, we need to evaluate as well. And the importance of working locally, using strengths of local communities, and as you emphasised. So thank you so much. And mental health centre, I think that's beautiful.
Thank you.
Hello.
Yes, Colonel Rajinder Singh, please. Yeah.
It's a beautiful presentation and a very comprehensive and very excellent in every area. I think it's a very good and welcome shift from the molecule to the preventive aspects. And Dr. Murthy, whom I saw him here, I couldn't recognize because he's looking so young now. And this is a very absolutely welcome shift from the biochemical to the preventive aspects. And as Dr. Murthy remarked, that yoga, exercise, and diet, they are not to be discussed. These are the real areas which we need to be discussed in detail. And I must say they are with long-lasting effects and very cheap areas. And we can strike the root. This is working at the grassroots level. This is a very important area, the prevention of these drugs. Similarly, a burning problem, which we have now, drug addiction. Drug addiction, just if I am allowed to take 1 minute or so, is basically the problem is the prevention, because the treatment of drug addiction is absolutely costly. Psychiatrists are not available, and at the same time, it is you see, a chronic relapsing disorder, which we treat a patient for 1 month, 2 months, and after 6 months he is back. By that time, many other new patients have come up with addiction. So the problem lies in tackling the prevention. Prevention in this particular area, drug addiction, is reducing the availability, which many governments are trying, but they are not getting the results. They are failing, I must say. And the second most important factor is to reduce the demand of the drug. Demand can only be reduced by making the individuals very strong, so that they are morally and virtually, you see, they can influence, and they can influence people, and they do not get, you see, tempted to try drugs. The drug addiction, reducing the drug addicts, is no treatment of drug addiction in what I feel. Thank you very much. Wonderful seeing you, Dr. Murthy.
Thank you very much. Helen, would you like to respond? Yeah, we have a couple of other questions on the contact.
Yes, thank you very much, Dr. Carr. I think the importance of I think we could talk for another session on the importance of substance abuse, and you've brought up some critical points there. Thank you very much.
Yeah, I'm just conscious of the time, but we do have a couple of from the younger ones. So maybe, although I think these are very broad and very complex, interesting in their scope, but would you like to take up maybe one or two of them briefly before we end? You know.
Yes, thank you so much. I've noticed the comments from Dr. Sharma and Dr. Prashant. I think the importance of managing at the family level. I completely agree. This is support for young families, particularly those at disadvantage or with a history of, for instance, substance abuse and violence. This is important, both at a universal level, so family support programs at government level, as well as the sensitivities of community workers and local government or local organizations to support families in difficulties. And even in, I think in starvation conditions, in famine conditions, the importance of stimulation for child development and mental health has been recognized as very important. And then I think the reference to the Harvard happiness study is a wonderful one, because this the social connection is the basis of mental health, and that loneliness is a recognized risk factor. So acting at neighborhood level with people either elderly or isolated parents, or and working in schools to skill young people in social and emotional development is important. It has been shown to be very effective in improving mental health in later life.
Yeah, thank you. Thank you so much. I mean, as you correctly said, we could actually go on for a full fresh session on various aspects, because what you presented was a very broad bird's eye overview of but I believe may I request all, just for a second, if you can, to put on your video so that we can have a screenshot with Professor Herrman there. If Swapnajit, if you can just pin her is a very bad way of putting it, but you know, I mean, to make the picture more prominent and do something technologically to have a snapshot of that. I wish we could have taken more, but maybe we'd like to in India, when the Coca-Cola advertisement started 20 years ago, they had their tagline, advertisement tagline, saying in Hindi, they said, "Ye dil mange more," which means this heart wants more, you know. So just something like that probably we'd like to have you again. As I requested, we have our Diamond Jubilee International Conference coming up in September in the honor of Professor N. Vig and our Foundation Day. We'll see how it works out. Probably won't be able to make it in person as you wrote, but maybe we can have something like this as a plenary session there again. So yeah, I think we have most of us here. So Swapnajit, if you can just do the whatever is the necessary thing, I don't know, the screenshot.
Done, sir.
Done. Okay, and then can we, as I say, that we can never pay Professor Herrman. Obviously, she's unpayable. But can you please just put up that? Yeah, this is our very small, humble way of as a token of our appreciation. Yeah, the next one, please, so that we can have this. Yeah, so this is just a certificate of appreciation, Helen, for our heartfelt gratitude and we for your talk, and we are going to remember this. With your verbal consent, if that's okay with you, we'd like to put it up, an edited, slightly shortened version in our departmental YouTube channel, which is highly subscribed, and if that's okay with you.
Yes, of course. Thank you. I'll be pleased with that.
Yeah. Any last closing comments from you, madam?
Well, thank you so much. Just to say, I've thoroughly appreciated and enjoyed being here. And thank you, Devasish, for your leadership and